So our goal in this study was to describe the impact of genetic diagnosis on medical management in a cohort of individuals with pediatric epilepsy. And our study population was composed of 152 children seen at Boston Children's Hospital who had a diagnosis of epilepsy and whose workup included an epilepsy gene panel or an exome test. So all of its children who participated had first an epilepsy gene panel, and then some of them had an exome as well. We reviewed the medical records for these individuals, and we classified the impact of genetic diagnosis on their medical management according to 4 categories. Care coordination was the first category, treatment was the second category, change in prognosis was the third category, and a change in diagnosis was the fourth category. Some phenotypic features of this group included epilepsy onset, mean was 6 months of age, about 75% had refractory epilepsy, and around 70% had an encephalopathy pattern on their EEG. And the main finding was that 72% of individuals had an impact on medical management as a result of their genetic diagnosis. According to the 4 categories I mentioned, almost 50% of individuals had an impact on care coordination, and this included referral to specialists, diagnostic testing to monitor for disease-associated features, and referral to disease-specific clinics in some cases. An example is an individual who was found to have a variant in the gene KANSL1, and this individual was referred for a renal ultrasound due to the risk of urogenital abnormalities. In terms of impact on treatment, 45% of individuals had an impact, and this included choice of their antiseizure medications, access to gene-specific clinical trials or investigational drugs, use of gene-specific vitamin or metabolic treatments, and even use of some pathway-driven off-label medications. One example of this is an individual who had a variant in the gene PRRT2, and treatment with a specific anti-seizure medication is known to help with these variants. So they were treated with oxcarbazepine and had a very good response to that medication. In terms of change in prognosis, almost 30% of individuals had a change in their prognosis as a result of the genetic diagnosis. And this included cases of a benign prognosis and also cases of poor prognosis, depending on the gene that was found. And finally, we found that 1% of individuals had a correction of their diagnosis as a result of their genetic results. This was the case for 2 individuals who were considered to have a primary mitochondrial disorder and their diagnosis was clarified thanks to the genetic testing. Even though there have been many studies describing the theoretical impact of a genetic diagnosis according to the pathways of different genes, there really aren't any studies prior to this one that report on the impact of a genetic diagnosis on medical management in a clinical setting. And since we found that nearly 3/4 of individuals in the cohort had an impact on medical management as a result of their genetic diagnosis, we consider that genetic testing should be part of the standard evaluation of individuals with unexplained pediatric epilepsy. And this is particularly important to note because disease-modifying therapies such as gene therapy and antisense oligonucleotides are currently in development for a number of genetic epilepsies.
So we're excited that this is really showing real impact in our clinics, and that's even at a level of not manipulating the gene itself. And it's only going to be more important as it's really critical to have diagnoses to get into clinical trials, whether those are disease-specific small molecules or actual disease-modifying ones, like Dr. Haviland mentioned, and those are in development for a number of our disorders, quite a few pathways that are being targeted. So it's really critical, and there have been, as we'll get to in a minute, some limitations at many centers. At larger centers, genetic testing is really becoming standard of care, thankfully, but we're evolving our methods to exome and I think soon to genome. And we really need to get genetic testing to the smaller centers as well and overcome some of those hurdles.